My name's Siamusa, Mr. Siamusa, student tutor from Sang University. Today we are going to look at peptic ulcers in medicine. And by introduction, we are saying an ulcer may occur in any part of the GIT that may come into contact with the gastric juices. The ulcer may be found in the lower esophagus, stomach, or duodenum. Gastric ulcers are more likely to occur during the 50s and 60 years of life. And we are saying duodenal ulcers are more common occur during the 40s and 50s for men. And we are saying men are more likely to have both gastric and duodenal ulcers. When we come to definition, we are saying peptic ulcers, this is simply the peeling off of the top layer of the GIT, which can be caused by Helicobacter pylori, characterized by epigastric pain, vomiting, and weight loss. We're also saying, we can also say, define it as peptic ulcers as an excavation formed in the mucosal wall of the esophagus, stomach, or duodenum. So we are saying these ulcers, they are classified into two. It can be acute or chronic. And we have got three types of peptic ulcers. And we are saying these types of peptic ulcers, they are named according to the location. If they are located in the esophagus, they are called esophageal ulcers. If they are located in the duodenum, they are called duodenal ulcers. If they are located in the stomach, they are called the gastric ulcers. I'm sure you and me, we looked at the anatomy of the GIT. You may understand more if you happen to go back to your anatomy and know the anatomy of the GIT. This is what I was talking about, where you can find the common site for these ulcers. I'm sure I've talked about this. And when it comes to the causes, we say it is caused by Helicobacter pylori, and the causal factor in more than 90% of all peptic ulcers has been attributed to Helicobacter pylori. When it comes to predisposing factor, when we look at the predisposing factor, we'll list them, then we'll talk more when it comes to the pathophysiology. The first one is non-steroid anti-inflammatory drugs, e.g. aspirin and corticosteroids. I'm sure we talked about this when we are looking at it, and when we are talking about analgesics in class with you. When we talked about non-opioid drugs, we talked about SADs. We've got severe stress. It can be in trauma, occupation stress, emotional tense people. We've got heredity, such as people with blood group O and blood group A. Excessive intake of alcohol is one of them. Smoking, certain medication conditions such as gastritis, Zollinger-Ellison syndrome is one of them. Now let's look at the pathophysiology. And in the pathophysiology, that's where we're going to talk more on the predisposing factor. We're going to look at how can excessive intake of alcohol, how can it cause peptic ulcers, or how can it cause ulcers. Now we are saying the stomach, in a normal sense, when it comes to GNC, you have to explain the normal before you go to the abnormal. So we are saying the stomach lining is covered by thick protective layer, which prevents it from injuries. And one of them is prostaglandin. Prostaglandin, it acts as one of the protective layer of the stomach. And we've got epithelial cell within the stomach. And epithelial cell, the function of epithelial cells, it's secrete bicarbonate acid. So what normally happens when it comes to peptic ulcers? During a meal, when this person is having a meal, there's this hormone called the gastrin hormone. This gastric hormone is among the G cells. So during a meal, This is the hormone which will trigger the vagus nerve to release this hydrochloric acid, so that the function of this hydrochloric acid is to make the stomach acid, the stomach environment acidic. Two, also you want also these gastric juices to act on, like pepsin enzymes to act on, and also this hydrochloric acid, it can also kill bacteria. If someone happen to ingest bacteria due to this environment which is too acidic, the bacteria can be killed. Now let's look at how can excessive intake of alcohol, how can it can cause peptic ulcers. To some people that take alcohol, they may understand when you happen to take alcohol, it may cause irritation within the GIT. It may cause irritation in the stomach. Once there is irritation in the stomach, within the lining of the stomach, it may cause inflammation. When there is inflammation, once there is inflammation, it means there will be also the protective layer of the stomach to be affected. One of the protective layer is prostaglandin. It will be affected, and prostaglandin is there to maintain the epithelial layer of the skin. The function of this epithelial layer is to produce bicarbonate acid. So as we said in our preamble, we mentioned once vagus nerve happen to produce hydrochloric acid, this epithelial cell, it will produce bicarbonate acid so that to neutralize the hydrochloric acid. This hydrochloric acid is so strong in such a way that without bicarbonate acid, it may bend the lining of the stomach. This is what happened. When it comes to the alcohol, when this person is taking this alcohol, there will be irritation of the stomach lining. Once there is irritation of the stomach lining, it may disturb the epithelial layer. This epithelial layer is there to produce bicarbonate acid. Now we are seeing a situation whereby due to this irritation of the stomach lining, we are seeing the situation whereby there is inhibited production of bicarbonate acid, and hydrochloric acid, it will be more, there will be imbalance between the hydrochloric acid and bicarbonate acid, and cause the peeling off of the layers of the stomach. What of when it comes to smoking? We are seeing smoking, it can be one of the causes, one of the predisposing factors of peptic ulcers. How can smoking cause peptic ulcers? We are saying smoking can cause peptic ulcers in such a way that when you smoke, it will cause high, or it will disturb the gastrin hormone. This gastric hormone, it will be produced in excess in such a way that it may trigger the vagus nerve to produce hydrochloric acid, and hence causing the peeling off. There will be more production of the hydrochloric acid than bicarbonate acid. It can also cause irritation within the epithelial cells, and cause the epithelial cell not to produce bicarbonate acid, and cause the peeling off of the skin, on the top layer of the skin. We've got also Zollinger-Ellison syndrome. How can Zollinger-Ellison syndrome cause peptic ulcers? We are saying this Zollinger-Ellison syndrome, it can cause peptic ulcers because people with this disease, there is more production of the gastrin hormone. Once there is more production of the gastrin hormone, these hormones, they may trigger the vagus nerve to release hydrochloric acid. So there will be more production of the hydrochloric acid than bicarbonate acid, and cause the peeling off of the top layer of the stomach. And that's all about the pathophysiology. If you've got a question, you may ask, you may continue, you may ask. Now we are going to look at maybe we can look at the SADS and H. pylori. When it comes to H. pylori, we are saying H. pylori is one of the It's the major cause of Helicobacter pylori because it's accounted about 90% of people with peptic ulcers. When it comes to H. pylori, the H. pylori is the normal flora of the GIT. So, what will the H. pylori do? How can H. pylori cause peptic ulcers? We are saying this H. pylori, due to this acid, it may cause, it may weaken the immune system. It may weaken the lining of the stomach. Once they happen to cause weaken the lining of the stomach, we are saying this bacteria, instead of being a normal flora, it now started fighting on its own, autoimmune, started fighting on its own. Then we have also SADs. How can SADs, non-inflammatory drugs, how can they cause peptic ulcers? You and me in class, we talked about it. Example of SADs, we have got brufen, diclofenac, and brufen, diclofenac, etc. What do these do? We are saying prostaglandin is one of the protective layer of the stomach. So these what they do when someone happen to be on these drugs, brufen. You and me, we mentioned these drugs, they will act on the COX enzyme. These COX enzymes is the one that produce prostaglandin, which is the protective layer of the skin, protective layer of the stomach. So once someone is on these SADs, it means these SADs, they will inhibit the production, which means this coxygenase enzyme, it won't produce prostaglandin, and prostaglandin is the one that's maintaining epithelial layer, and this epithelial layer is its function to produce bicarbonate acid. Now, since this protective layer is not there, what will happen? There will be high production of prostaglandin. There will be high production of hydrochloric acid, and there will be no production of the bicarbonate acid. Now let's look at signs and symptoms. Signs and symptoms, as we talked about, we have got epigastric pain, which is a burning pain, which will be related to food, radiating to the back due to the erosion of the mucosa lining. Pain in the duodenal ulcer relieved by food, or gastric acid aggravated by it. So these people with duodenal ulcers and people with gastric ulcers, they will present signs and symptoms different. So someone with duodenal ulcers, if they had pain when they happen to eat, that pain will go away. But someone with gastric ulcers, and these people, they are at risk of weight loss. Why? Because this person, they'll be scared to eat. Whenever they eat, that's when they'll feel that pain. We have got also heartburn. Burning sensation experienced in some patients due to excessive presence of acid in the esophagus and stomach. We have got also vomiting due to irritation, which will cause inflammatory process. It will disturb the GIT function. Once the GIT function happen to be disturbed, it may cause reversed peristalsis, and once they cause reversed peristalsis, may irritate the nerve ending. This nerve ending, due to this pain, it will be the one that will trigger the vomiting center, and this someone will present with this. Weight loss, as we talked about, anorexia, which is the patient with gastric ulcer. The reason why they have anorexia, because people now, they are scared to eat because of whenever they eat, they'll have this pain. We've got hematemesis or menorrhea resulting from gastrointestinal bleeding from eroded small blood vessels. Hematemesis, which is vomiting of blood. Menorrhea, which is store in the feces. They have constipation due to inadequate intake. And this diagram, we're just talking about the difference between gastric ulcers and duodenal ulcers, of which you can say it by yourself, and we have talked about it already. Now, management, as when it comes to GNC questions you have to face when it comes to management. You have to come with aims. What would be your aim? One, you want to relieve pain. Two, you want to eradicate the cause. Three, you want to modify the diet. Four, you want to prevent complications. Then, as GNC, when it comes to management, it comprises of nursing care, medical investigation, nursing aims, investigations, medical management, and nursing care. So when it comes to investigations, each point that you mention, when you mention about 1 point, it's just 2 marks. So we'll first start with history taking. History taking. Someone will come with a history of maybe chronic, it can be chronic or acute, smoking, coffee, drinking, use of steroid. Will come with this history. You ask the patient, will tell you that yes, I'm on this drug, I'm on this side. Or you ask if either the patient is stressed, you just, it's on history taking. You ask them, you have got 2 points, 2 marks. Physical examination, assessment for any tenderness over the involved area of the abdomen with proliferation, there will be severe pain. Then we can also come to radio endoscopy. This endoscopy to visualize and identify the inflammatory changes. Lesion, that the major diagnostic test is esophagogastroduodenoscope. This is one of those things that will be used. You can also do barium swallow, where we give a white steamer-like substance, whereby when someone swallows, it's going to help us to visualize if there's any lesion within the GIT. You will see. We have got stool examination to detect melena. We have got monoclonal stool antigen tests used to diagnose the presence of Helicobacter pylori. We have got gastric analysis to help in differentiating gastric ulcers from gastric cancer. If you have got any question, you can ask. When it comes to medication, when it comes to GNC, you have to name the same drug, the mode of action, the dosage, the side effects, and nursing implications. You have to know this. So the first line therapy use proton pump inhibitors and the combination of 2 antibiotics. For example, omeprazole, clarithromycin, and metronidazole. Now when we mention this, we have to mention the drug, the dosage, the action, the side effect, and nursing implications. We've got omeprazole, 20 milligrams orally, twice daily for 4 to 8 weeks. What will the action of this? This is a proton pump. What will omeprazole do? It will inhibit the production of hydrochloric acid. It will act on the vagus nerve to reduce the production of hydrochloric acid. Side effects we have got NVD, nausea, vomiting, diarrhea. Nursing implication, you will caution the patient not to perform hazardous activities if dizziness occurs. Then we have got also amoxicillin. Amoxicillin 500 mg TDS oral, 5/7 for 5 days in short. It's also this one is antibiotics. Its action is to block the protein synthesis. It's more like a bacteriostatic. Side effects: NVD, nausea, vomiting, diarrhea. Nursing implication: you caution the patient with hepatic or renal impairment. Obtain urine specimen for culture and sensitivity test before the first dose. Then we have got also metronidazole, 4 milligrams oral TDS for 5 days. It also inhibits protein synthesis of this Helicobacter pylori. Side effect: NVD, metallic chest. Nursing implication: instruct the patient to take drug with food. Then if that's the first line treatment fails, then you change, you come to the second line therapy. But during GNC, they will tell you either to use second line treatment or first line treatment. So when it comes to first line treatment, you mention those three. They just want three drugs. That's all. From there, you can also give antacid. The antacid they want to treat, they will just neutralize the hydrochloric acid, the stomach environment. They will just make it neutral. Then from there, you come to the nursing care. Nursing care will use a propionema. You mention your aims. Then from there, you list you start from environment, your goal, pain relief, psychological care. I'm sure we know a nursing care, most of us. So just to go through, you come to complications. Anemia is one of them. Hemorrhage is one of them. Shock, perforation or peptic ulcers, peritonitis. That's all for this session. If you've got a question, you can come. See you next time.